Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the healthcare lawyers at Epstein Becker Green, a leading law firm that has more than 40 years' experience serving clients in the healthcare industry nationwide.
Today on Diagnosing Healthcare, we will highlight and discuss the key healthcare policy priorities and developments to watch as we enter 2023. Hello and welcome. I'm your host, Ted Kennedy Jr. I'm an attorney in Epstein Becker Green's healthcare and life sciences practice. With the recent election that has changed the composition of Congress and the Biden administration's first opportunities to advance its policy priorities from the very beginning of the rulemaking process, we'll expect 2023 to be a very interesting year in healthcare policy. We will also be closely monitoring the implementation of the Inflation Reduction Act and the drug pricing provisions, which really represents the most significant healthcare policy development since the passage of the Affordable Care Act in 2010. The objective of this episode is to discuss the current landscape of healthcare policy from both the legislative and regulatory perspective and to analyze the key healthcare issues to watch in 2023. If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts. Let me introduce my guests today. Joining us in our discussion is Philo Hall and Alexis Boaz from Epstein Becker Green's Washington, D.C. offices. Philo advises healthcare clients on complex reimbursement and compliance rules and other issues before CMS and the Department of Health and Human Services, or HHS. Prior to practicing law, Philo served as counselor to the Secretary of HHS. Earlier in his career, Philo worked on healthcare issues at the White House in the George W. Bush administration and the Senate Health Committee, which is the Committee on Health, Education, Labor, and Pensions. We're also joined today by Alexis Boaz. Alexis currently advises clients on a wide range of healthcare regulatory and policy issues, with a specific focus on surprise billing, transparency, and drug pricing. Prior to joining EBG, Alexis worked as an intern in the Obama White House, as a law clerk with the Senate Finance Committee, a healthcare policy fellow with the Congressional Black Caucus Health Brain Trust, and as an intern with both the Senate Health Committee and at HHS. Thank you so much for joining us. So before discussing potential legislation that we might expect for 2023, I'd like to first begin by discussing the implications of a split Congress and how that impacts healthcare policymaking. We know that during the 2022 midterm elections, Republicans won control of the House, while Democrats gained an additional seat in the Senate. So now we have a split Congress, which is the first split Congress since 2018, and the first Republican House Democratic Senate split since 2013. Philo, let me begin with you. How do you think that this split Congress will impact the healthcare legislative landscape during this next Congress?
Well, thanks, Ted. Yes, it will certainly be a different dynamic than we've seen for some time. We will see the end of large, partisan, sweeping, transformative legislation. Bills such as the Inflation Reduction Act, the Consolidated Appropriations Act, one of these big omnibus bills, or the Affordable Care Act, or anything as ambitious as Build Back Better. Bills that are truly transformative and represent one ideological view that is passed on a partisan basis with one party support, that's off the table, of course. There's very little in the broad Republican priorities that Democrats agree with, and very little that the Democrats would love to see in their ideal world that Republicans would agree to in the House. So that means that we're going to have to see narrower bills where there is some sort of bipartisan compromise or agreement, or bills that absolutely must get passed.
Do you have any observations about the new committee leadership on the various committees of jurisdiction over critical healthcare policy issues, both on the Senate side and on the House side?
Sure. And those committees, I think, are going to illustrate one of the aspects of split leadership. So while I said there's no major laws that are going to pass that are very ideological, I think because Congress is split, you're going to see the committees in each of the different bodies of Congress putting forward a lot of proposals that are very partisan and very ideologically extreme and with very little potential for passage. So, for example, on the House side, with new Republican chairman of the Energy and Commerce Committee and the Ways and Means Committee, they have emphasized that I think they understand that they cannot pass anything to repeal the Inflation Reduction Act or anything like that. But what they can do is very aggressive oversight of the Biden administration, maybe criticizing the Biden administration policies through the IRA or through COVID response. So the chairmen there have said that they intend to spend a lot of time critiquing and looking at every step of the implementation of the Inflation Reduction Act, of the No Surprises Act. And I think particularly you will see a lot of focus on the origins of COVID. Like, how did the government not track or identify the origins of COVID? Was there a China connection? What it was? And what did CDC and HHS do in responding to COVID that the House Republicans may perceive as inadequate or beyond their authority or counterproductive? And you see that there's a tenor of this, and I think you'll see something similar on the Senate side with the Democrats, of playing to the base. These are things that are not going to pass, but it is still intended to distinguish one party from the other. See, that's the goal of it, is to say, in our ideal universe, this is what we could do if you would only elect us to be a majority of the entire government. So there's a distinction there. And maybe Alexis can talk about what some of the Senate Democratic priorities might be in the committees there.
Thanks, Philo. Bernie Sanders is going to be the chair of the Senate Committee on Health, Education, and Labor, the HELP Committee. And his priorities, of course, are very far left. So for healthcare, he's focusing on universal healthcare and lowering the cost of prescription drugs. There's been a lot of trade press on sort of guessing how Senator Sanders will handle being in the leadership position, how he'll adjust to some of his policy proposals, but then also how receptive he'll be when meeting with different stakeholders, meeting with different corporations on their issues. But he's worked with Senator Cassidy in the past, but we'll also see how that works going forward with him in a leadership position. And I'll let Philo talk about the priorities on the Republican side of the Health Committee.
So the new incoming ranking member for the Senate Health Committee is Senator Bill Cassidy of Louisiana. He is a physician. He's a gastroenterologist. And he has been very active and very involved in healthcare legislation in the Senate for the last few years, very instrumental, or has found ways to insert himself in the No Surprises Act and a number of other bills. The Republican caucus there likes to use him as a leader, as a face of their proposals, because he is a doctor. Again, as Alexis said, while Bernie Sanders may want to talk about Medicare for all or prescription drug importation. That's, of course, off the table for Senator Cassidy. But I think he is interested in some issues where he can probably work with Bernie Sanders, and there can be some substantive, responsible policymaking. I think they do certainly have shared interest in reducing the cost of prescription drugs. Now, Bernie Sanders and Cassidy have different views on what that might be, but at least they will be talking about the topic, and maybe they may settle on some compromise or nonpartisan, non-extreme provisions to advance the discussion on the cost of prescription drugs. I mean, notwithstanding the passage of the IRA. So I think both Cassidy and Sanders will want to see oversight of how the administration is implementing the IRA to allow negotiation of Medicare drug prices. Senator Cassidy, I think, is also going to be very interested in examining, are there additional pandemic preparedness authorities that are needed, or are there adjustments to current authorities for how our agencies respond to pandemics? That's also something that he may have buy-in or agreement with Chairman Sanders. And then I think there are a few, we talk about the high-profile issues, but I'm confident that they will find a few other issues to work on. Implementation of the No Surprises Act on surprise medical bills. Is that problem being solved? Fentanyl is an issue that they can both work on. It is impacting a lot of rural communities across the country, and both Cassidy and Sanders are from rural communities.
So, Alexis, let me turn to you. Philo mentioned the surprise billing implementation. The No Surprises Act went into effect last year, but I'm wondering if you have any insight about how that process is being implemented administratively and whether we're going to see any litigation or slowdown in the implementation of surprise billing.
Yes. So the No Surprises Act went into effect in January 2022, but there was a really short lead time between when the law was passed and when the law went into effect. So about a year, where HHS had the opportunity to go through rulemaking. So even in the early rules, HHS told stakeholders that they wouldn't have all of the regulations out that would be needed before the law was to go into effect on January 1st. So there's sort of three parts to the No Surprises Act. There are the balanced billing prohibitions, there are the transparency provisions, and then there's the good faith estimate requirements. So of course, the surprise billing protections, those are the provisions that prohibit balanced billing for out-of-network emergency services and certain out-of-network non-emergency services. And even though those regulations were issued by the time the law went into effect, there's been some delays as far as rulemaking goes due to some litigation that has addressed one of the key issues from when the law was being debated on the Hill, which is the out-of-network payment amount, which is determining the out-of-network payment amount that plans must pay out-of-network providers for out-of-network services. So when the law was being debated on the Hill, that was one of the central turning points and areas of contention. And so when HHS released a rule, a lot of stakeholders, particularly in the provider and facility side, challenged the rule. A federal court vacated that portion of the rule. And since then, HHS has issued a different version of the rule. And that rule is also under challenge. And I say HHS here, but really the No Surprises Act applies to a broad range of plans, including employer-sponsored plans. So this includes Department of Labor, Department of Treasury, and the Office of Personnel Management. But that really slowed down rulemaking a lot. And so there's a lot of remaining provisions that HHS has to address. There's also an issue of overlap between some of the transparency provisions within the No Surprises Act and some of the recent transparency and coverage rules. And then also issues where components of the No Surprises Act have been almost completely delayed by HHS due to some interoperability issues. So I would not be surprised to see some oversight addressing some of those delays with rulemaking, some of the issues with how HHS interpreted Congress's mandate, particularly with regard to the out-of-network payment amount and those types of issues. Those are some of the issues that I would expect for the HELP committee to try to address.
Thank you, Alexis. In addition to surprise billing, it sounds like prescription drug pricing is still a key priority for both parties, even though the Inflation Reduction Act was signed into law last August. But I'm curious, Alexis, where are we with the implementation of the Inflation Reduction Act drug pricing provisions?
One of the most high-profile provisions of the drug pricing provisions of the IRA would be the provision allowing Medicare to negotiate and set maximum fair prices for certain drugs. There are also other provisions that HHS will work on implementing, such as the Part D redesign, requiring manufacturer rebates when certain drug prices rise faster than inflation, and other changes. But a lot of the tension right now is focused on the Medicare drug negotiation and maximum fair price. And one of the interesting things about the IRA is that unlike the No Surprises Act, which set out very specific parameters of what rulemaking the Secretary of HHS has to issue, when HHS has to issue it, and what needs to be required, there's really not as much of a streamlined process set out by the legislation. So there is a sort of due date for September 1st when HHS will have to publish the list of drugs that will be subject to the maximum fair price. And HHS has already started holding stakeholder meetings to get input and to answer stakeholder questions, but they really still haven't given a timeline of how HHS plans to collect stakeholder feedback and the process they'll use to collect and respond to stakeholder feedback. So that could definitely be an issue later with if there are any challenges to the administrative process that HHS uses to implement the IRA. But even in the calls that have been held as of now, HHS has not really gone into detail of the timeline or how they're going to collect some of this stakeholder input. So there definitely will be areas that Congress could look in for that. But then, as Philo mentioned, there are also areas where both Sanders and Cassidy might believe that the IRA didn't really go far enough in addressing some of these drug pricing issues.
Thank you. Before discussing other Republican or Democratic healthcare priorities, I wanted just to take a look back and get your thoughts about the lame duck session, when Congress included many healthcare provisions in the Consolidated Appropriations Act just last December, signed into law December 29. What were the key issues that made it into that law, and what may be issues for which there may be strong support in Congress that did not make it into that omnibus bill? Philo, could you help us understand some of the key provisions that were in and that were left out that may be taken up in this next Congress?
Certainly. We'll start at the very top of the priority list. Maybe one of the highest profile issues that was included was relief for Medicare physician payments. Under the Medicare system, physician payments that were scheduled to go down about 4.5% in 2023. And Congress provided partial relief by bumping those payments up slightly so that physicians for 2023 are facing a roughly 2% cut. That's not something that physicians like, but they prefer a 2% cut to a 4.5% cut. Another issue was Congress waiving what's known as the pay-go cuts. I mean, this is a automatic cut triggered by earlier budget legislation that would result in across-the-board 4% cut to all Medicare providers. That's physicians and hospitals, all manner of facilities, all manner of healthcare services were scheduled to be cut by 4%. Now, Congress has waived the pay-go cut annually really since it went into effect, but lately Congress has been waiting to the very last moment to waive these cuts. So it gets to be sort of a high stakes matter of hoping you don't fall over the cliff and get a nationwide 4% Medicare cut. But that was waived again by Congress. I think another big issue, maybe the biggest issue for states, for state Medicaid programs, was Congress allowing states to reinitiate Medicaid determinations beginning April 1st of 2023. So recall that as a part of enhanced support for Medicaid programs, expanding coverage and availability of coverage during the COVID pandemic, states were prohibited from making redeterminations during the public health emergency. And redeterminations is, reevaluating who is eligible for Medicaid benefits. Well, this has meant that no one has been moved off of the Medicaid roll since the beginning of the pandemic, regardless of if they still have financial need or if they're eligible for coverage in other places. And so states know that it's going to take a long time to do all the redeterminations and right-size their Medicaid population. And so they were asking Congress that they not have to wait till the end of the public health emergency, that they can start by a date specific. So Congress granted them that. Congress also did a permanent extension of the 12-month postpartum Medicaid coverage option for states. And a very interesting thing is, again, these are all sort of like extensions of what came out of, or what were flexibilities and enhancements added during the COVID pandemic. Another one was born out of necessity during the pandemic, as Medicare allowed some inpatient hospital services to be delivered to patients in their homes. Where it was technologically feasible, CMS allowed and would reimburse hospitals to deliver and bill Medicare for services delivered to patients in their homes. There are actually quite a number of services where this was a great innovation. It was better for the patients, and Congress is not ready to pull the plug on that innovation with the end of the pandemic. So they extended this waiver program through the end of 2024. I think there were some other COVID-related flexibilities that were continued in this bill, particularly around telehealth. Alexis, could you speak to those?
Yes, there were quite a few significant extensions of some of the COVID-related telehealth flexibilities for Medicare. Some of these include the waivers related to geographic restrictions, the list of eligible practitioners who can furnish telehealth care, and delaying the in-person visit requirements for telehealth services. A lot of those requirements were some that stakeholders have really been pushing for. So those have been extended for another 2 years. In addition to extending some of the telehealth COVID flexibilities, the Consolidated Appropriations Act of 2023 also included some expanded authorities for FDA. Previously, FDA would determine whether a product was safe and effective for its intended use. But under the CAA, FDA can now issue a use-specific ban on medical devices, which might impact how healthcare professionals are able to use devices off-label. So this really expanded the scope of FDA's authority in this space. We'll have to keep an eye on implementation of this new expanded authority in 2023.
Let's turn now to the legislative priorities for 2023 and understanding issues that may not have been dealt with in the lame duck, but may nonetheless have some bipartisan support. Alexis, are there any such issues that you can think of, such as mental health or PBM reform or other issues like that, that you think may get traction this Congress?
Yes. As I mentioned during the discussion about drug pricing, there is a lot of alignment between both parties in Congress, with the administration, and on the state level of sort of an anti-PBM sentiment. So there could be some legislative action addressing some of the policies for PBMs, particularly regarding rebates and the fees that PBMs collect from drug makers and pharmacies. Mental health is definitely an area where both parties seem to have prioritized. The CAA included certain mental health provisions as far as allowing Part B coverage for marriage and family therapists and mental health counselors, and some additional payment changes to help push psychotherapy. But the CAA didn't include certain provisions on mental health parity, which the chair and ranking member of the Senate Finance Committee had sort of pushed late in the previous Congress. So that's definitely an issue that could come up again and have bipartisan support.
Philo, I'd like to turn to you and to ask you to comment on whether or not there are any physician-related legislative updates going into 2023.
Yes, I think there are, and it ties into the Consolidated Appropriations Act, the omnibus during the lame duck that we just mentioned. I mentioned that Congress gave relief to Medicare physician rates, as Congress has had to do several times in the last 4 or 5 years, because CMS has set up a system where, to maintain budget neutrality, if the Medicare program increases payment rates for some providers, it has to offset that with across-the-board cuts to others. And that is why Congress has stepped in several times to phase in or prevent cuts of, like, say, 4 to 5 or 8% coming in on providers in 1 year. That's a flaw in the system, and Congress recognizes it as a flaw in the system, mainly because they don't like repeatedly having to focus on this year after year. They like to work on new issues. So this has made some in Congress a little bit open to Medicare physician payment reform in 2023. There was a group of physicians in the House, Republicans and Democrats, particularly on the Energy and Commerce Committee and others, who put out a request for information asking physician stakeholders for ideas about how the system can be updated or should be revised, particularly to improve or continue incentives so that physicians undertake value-based care. But I think they also, as a part of this, want to set up a system where they do not have to bail out physicians from large cuts on an annual basis. This is a type of process that I don't think will lead to legislation in the next Congress, but maybe after 2024. But I think this is an important step of beginning the dialogue. I think maybe ideas will be discussed and proposals at least get put down on paper in the next Congress, 2023, 2024.
I wanted to get your insights and analysis about administrative priorities and what's happening at CMMI, their specialty care models. Any thoughts that, Philo, you may have on what's going on at CMMI that could be developed into more comprehensive healthcare policy and other priorities at HHS?
Certainly, CMMI has quite a lot of work to do in this administration. CMS set a goal with CMMI, their pie in the sky goal. They're sort of like grand objective that by 2030, all Medicare providers would be under some payment system where they are at risk for the health of an entire population, and they're paid for their patient population. They're paid based on the patient population, and that they face positive and negative risk. That's like what CMS considers full value-based care. Now, CMS is a long way from getting there. CMS has admitted, and CMMI, the Innovation Center, as a part of CMS, they've admitted that they're struggling with how to set benchmarks for providers in these models and how to integrate primary care and specialty care in one population-based model. They have models for primary care. They have episode-based payment models for specialty care. They're going to work on combining them. And it is a challenge. They've shared some concepts in 2022, but I think the big next step will be in 2023. CMS has said they will be releasing a request for information to get a lot of stakeholder input on how to integrate specialty models and specialty care into population-based primary care models. So it's very important that stakeholders and providers look at the principles that CMMI has released to date and respond to that RFI later in 2023.
Are there any other highlights from CMS or any other proposed rulemaking that you would highlight for our listeners today?
Yes, one other that I think is going to be exciting, and it's a signal from CMS of what they will propose in 2023, but they've made clear that during the year, they will issue a proposed regulation to set up some manner of expedited pathway to Medicare coverage for breakthrough medical devices. This is going to be the Biden administration's scaled back version of a very aggressive rule proposed in the Trump administration that would have had automatic Medicare coverage for any device that the FDA classifies as a breakthrough device. The Biden administration has signaled they're going to try something a little more modest, a little more incremental, perhaps allowing CMS to work with manufacturers on a Medicare coverage pathway even before FDA has granted market approval, sort of work on a dual path towards Medicare coverage, something that is very important to a lot of innovator devices who otherwise have felt themselves caught between the cross purposes of getting FDA market approval by one set of standards, which might actually be counterintuitive and counterproductive, trying to achieve and justify Medicare coverage through CMS coverage standards. So I'm very much looking forward to that.
Alexis, what about any other HHS priorities that you would highlight?
Yes, I would definitely highlight the good faith estimate requirements under the No Surprises Act. I mentioned those briefly before, but there is a requirement for providers and facilities to provide good faith estimates to, as of now, uninsured and self-pay patients. But later, the No Surprises Act also included a requirement for facilities and providers to give a good faith estimate for covered patients as well. Under that legal framework, plans would then have to use that information to provide patients with an advanced explanation of benefits. The entire framework for covered patients and certain elements of the requirements for uninsured and self-pay patients have been delayed because providers, facilities, and plans don't all have the ability to transfer the information for good faith estimates to each other between the parties, from facilities to different providers, and then also to transfer that information to plans. One of the major areas for rulemaking that we'll be looking for is whether and how HHS will require all providers, facilities, and plans to adopt standards-based API to enable them to transfer that implementation between all the different parties. So it'll be very similar to some of the issues that we saw with implementation of electronic health record standards, but sort of on a different level as far as the types of information that'll have to be transmitted and the timeframes. Those are some of the areas we'll definitely see some activity from HHS, and there are also similar proposed rules to similar interoperability standards. So those are definitely some areas that I would highlight as important for 2023.
And how about, Philo, your thoughts about the end of the public health emergency and what impact, if any, that's going to have on healthcare providers and life sciences companies?
Yes, well, a reminder that the administration has said that they're going to give us a 60-day notice on the end of the public health emergency for the COVID pandemic. And the current conventional wisdom is that the end will end up being in early April. We'll get word of that in February. You know, we've been discussing some of the elements of the public health emergency flexibilities that Congress has decided to continue. They're going to be valuable to many providers. But apart from that, we're going to see a lot of the flexibilities and requirements end with the public health emergency. And that's going to be a rough adjustment for a range of providers. Many have already been preparing to operate without the public health emergency flexibilities, but in terms of standards for billing Medicare and staffing issues, privacy issues, and claims issues under Medicare, those flexibilities will end. We'll return to the pre-pandemic compliance world. And there will be, I think, an adjustment with less generous coverage and protections around the coverage and delivery of some of the vaccines, treatments, and preventions for emerging contaminants. And in terms of the life sciences area, manufacturers and others will have to adjust for some impact on demand of fewer requirements on coverage and cost sharing that have incentivized uptake of countermeasures, of treatments, and preventive measures for COVID. So there will be adjustments. Hopefully, most members and stakeholders of the healthcare community have been preparing for this, but there are some, I think, who still have some work to do.
Thank you. As we conclude, I wanted just to turn to an issue that may be outside the purview of HHS. As you know, the FTC recently released a proposed rule that would ban all non-compete provisions from employment contracts. I'm just curious to know, I know this is a brand new issue on the national level, how that might impact physicians or other clinicians. Do you have any initial thoughts about that, Philo?
Well, this is quite an interesting issue, a development just that occurred yesterday, January 5th, the day before we're recording. FTC has a proposed rule that would ban non-compete provisions. And I'll just say anecdotally, a lot of people in our firm are talking about this, and there's a lot of different perspectives and issues from the employer perspective. From an administrative law perspective, I guess there are some questions about, I'm just told there are questions about how much rulemaking authority the FTC has or does not have. But I do know that this is exciting in shining a spotlight on what has certainly been a source of, I'd say, growing complaints from a lot of physicians and physician groups, particularly specialists, as consolidation in the healthcare industry has meant a lot of physicians choosing to undertake an employment relationship with hospitals or health systems. And non-competes have become a part of their way of life, and it has led to some tension. So I think there will be some very vigorous comments from the healthcare sector on this proposed rule. The FTC, I do know the proposed rule discusses the impact on physicians to some degree. So this is partially a measure as a part of the administration's goals to improve competitiveness in the healthcare industry. That's at least one of their stated goals with this. So I think there will be very vigorous comment from physician organizations. I think there'll be a lot of stakeholders weighing in for and against this rule, and I think there will be probably some litigation as well.
Thank you, Philo. Thank you, Alexis, for a great conversation. As we wrap up, I bring this podcast to a close, I just wanted to offer you each a moment to identify any other potential sleeper issues or any other predictions that you think might gain traction in 2023.
I'm happy to start. I think one sleeper issue that I'll be watching for, I'm not certain that's going to happen, but I have my suspicions, is as we see more evaluations come out of CMMI of previous Medicare value-based care models, and as Congress debates the future of incentives for physicians in Medicare value-based care, I will be looking to see if more policymakers publicly question whether value-based care has been a success in reaching its objectives of reducing healthcare expenditures in the Medicare program.
Alexis, any final thoughts?
One sleeper issue that I think has not had a lot of attention just due to all the other activity around implementation of the No Surprises Act would be the enforcement provisions. HHS issued a proposed rule regarding enforcement of the No Surprises Act that included a lot of sort of extensive capabilities for HHS to enforce provisions for the No Surprises Act. So if these enforcement capabilities were to go into effect, they could be used by HHS to not only enforce requirements under the No Surprises Act, but also other regulatory frameworks such as transparency and coverage. It would allow HHS to be able to initiate investigations and just really might change how HHS is able to enforce some of these requirements. So HHS has not addressed the enforcement provisions for a while, but we are still waiting on a final rule for enforcement provisions. That's definitely an area to watch.
Well, thank you, Alexis. Thank you, Philo. We also want to thank the audience for listening today. If you enjoyed today's discussion, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts. See you next time.
Thank you for listening to Diagnosing Healthcare. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. The Employment Law This Week and Diagnosing Healthcare podcasts are presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of the legal services to be performed is greater than the quality of legal services performed by other lawyers.